Today my angle for this conversation is really tapping into the different lenses that I've had the opportunity to look through over the last 10 to 15 years. So with that, I'll put up this slide. 17 million by 2030. Does that ring a bell for anyone?
Worker shortage?
Yeah, actually, and you know, we've thought workforce shortage was in the order of 4 million for a number of years, and now as we're re-looking at this number, it's actually coming up to 17 million. So this is obviously, this is work done by WHO and the leaders in the field of global health workforce, recalculating what is the deficit of health workers. And where the deficit used to be built on looking at assisted deliveries, and we used to say, you know, we need about 2.25 health workers per thousand. Now using the principle of universal health coverage and 12 tracers so that they balance infectious diseases, non-communicable diseases, and maternal, child and infant health. They're now looking at those 12 tracers and saying, well, actually, we need 4.45 health workers per thousand. And so the gap becomes greater. So the numbers, so the current workforce, and you may be familiar with it, so I'm going to just brief on it. But you know, the current workforce is in the order of 42 million, about a 17 million current deficit. And on the current trajectory of both education and employment, we're looking at producing about up to 47 million by 2030, so about 11% increase. But this new need-based estimate, looking at the SDG tracers, suggests that we will need by 2030 54.5 million, 18% higher. And the gap, and it doesn't calculate exactly because I think it's based on distribution as well, but the gap remains the same. We were short 17 million today, and if we continue on the trajectory of growth, in 2030, we're still going to be short 17 million. So that's interesting. How do we close this gap? So obviously, we can produce more or retain more, increase the current pipeline, expand the number of programs, increase the bandwidth of the current programs. We can increase access to existing programs and reduce the brain drain. So that's much of the work that we've been thinking and doing. And then might we innovate? And how can we revisit these numbers? Can we improve the efficiencies of the existing workforce? Can we revisit the health service delivery systems and make them more efficient so that we're actually not requiring as much? So I pose these as questions. Not that I have the answers, but I think these are the things that we probably all think about. And as we sit back, and as particularly I've been sitting back to think about how are we going to bridge this gap, we look at the funding and financing of health workforce. Governments are certainly being pushed. They're already producing on track to invest and grow 10%. Can we really expect governments in low and middle income countries to expand 18%? Philanthropic organizations are contributing to global health, but even their contributions are getting smaller. So I think there are some new kids on the block, impact investors, for example. And it was actually and I think Kate and Heather, we were all there last year, where it was one of these, I'm a member on the National Academy of Science Global Forum for Innovations in Health Professions Education. There was a meeting. And they had invited an impact investor to share thoughts. So this particular speaker came from an impact investor, and you know, impact investors vary in their approach to impact investing. This group was impact investor. I'm going to get to it. So they actually are providing direct funding. So these are private funders looking for a double bottom line. They're looking for social returns and financial returns. So this is, to me, the new kid on the block of financing. These guys came to say, we're interested in investing, not just we, our investors are interested in health. So they did a landscaping study. They said, we're interested in health. We're interested in investing in health systems. We did a study. This is what they came up with. Note the absence of workforce. So they are interested in investing in diagnostics, in payment systems, in infrastructure, but nowhere on here in their landscaping study did they determine for themselves that they're going to invest in workforce. So I think we need to ask ourselves, why or how can we engage them, and why are they not engaging with us?
Incidentally, the report just came out from the IOM. Everybody can get copies. It's online.
Okay, perfect. So I'm going to pose some provocative questions that I tussle with. How can we engage, and why are these folks not engaging with us? Is it because we focus our workforce crisis often on numbers? And so we say we need X number of workforce. But there's a time, it's a long-term investment. You invest today, you hope to see the returns 5 years, 10 years, but wait, there's a brain drain. I can't even guarantee that the people you invest in are going to actually be there at the end of this. So if I'm an investor, okay, I have to take a hop, skip, and a jump to say that my investment will return. But beyond that, I don't think we've come up with surrogates to really capture the milestones of investment in workforce. We talk about retention, we talk about workforce numbers, those are long-term. What about quality? How do we describe the milestones of quality improvement? And I think the challenge is legitimate. Quality is built often on what's needed locally, and how can you come up with common currency around quality? So I think workforce crisis, while often described in quantity, and even if you look at this 2030 document and comb it, it's a lot of numbers. They touch on quality, and they start to talk about the need for balancing training for international markets versus local needs, but there's really no milestones in there. So I'm going to focus today on quality, and I'm going to come back, and this slide actually talks about quality across the spectrum. So this slide is looking at the 49 low-income countries for the WHO. The ones highlighted are the ones that I'm going to focus a little bit more on today. So Tajikistan, for example, is one of the 5 countries that actually has enough numbers. They can check the box that we meet the critical number of health workers. But they are such a fragile healthcare system. So we're going to talk today a little bit about how quality plays out across the spectrum from those countries that don't really have the numbers versus those who can actually say we meet the minimum number. So as I go into this talk, and what I wanted to do today was to focus on 3 innovations that we've observed over the last number of years. And I'm going to try to describe to you the local context, because I think you can't talk about quality unless you know the local context. Describe to you the innovations, and then try to put some results around these investments. So we can try to think about how do we describe quality as an investment that's measurable. So the two parts that I'm going to look at are workforce education, but then also looking at the existing workforce. And the 3 innovations I'm going to talk about are the use of technology, the use of a community-based training approach targeting existing health workers, and then the trend towards decentralizing workforce education and its impact both on the education but also on the service environment. So with that, I'll start first with technology. So first, the context. So the context of my description about use of technology in medical education comes from MEPI. Many of you around this table are familiar with MEPI. MEPI is winding down. It was a 5-year investment, US government investment, to really improve the capacity, the retention, and the research of medical health professions institutions in Africa. These were the programs that were funded. It was a competitive grant. GW was a coordinating center. So we had the opportunity, actually, an incredible opportunity, I might say, to visit and work intimately not only with these 11 schools, but I'd say probably 36 schools across the continent, and working alongside them, trying to look at what they're doing, how they're doing it, and what are the trends across this landscape of low and middle income countries trying to build capacity. So here's a context. I'm going to start setting there's 2 countries I'm going to set the tone for. Any guess where this is?
The Apple Factory.
Yeah, so you've been there. This is Tanzania, which I think is a pretty neat picture of Moshi, Tanzania. So this is actually at Kilimanjaro Christian Medical University College, one of the schools that got the MEPI grant. This country, Tanzania, has 1 doctor for 30,000. This school, KCMC, was started in the 1990s, in the late 1990s, had about a dozen students when they started, and now has ramped up to 125. And so setting the stage for context, their issue is faculty. They have trouble recruiting, retaining, and engaging their faculty. At least that was the way the stage was set before MEPI. Okay, so country number 2, just looking again at the investments in technology. Anyone? Ethiopia. This particular picture is one of my favorites because to me, it really sets the baseline for where we're at. So this is a community clinic in Ethiopia, it's Ziwai Clinic. Under the blue blanket is a laboring woman coming by ambulance on a donkey to a health clinic that's not staffed by a physician. So this to me epitomizes the workforce crisis. It's not just its numbers, it's distribution, it's quality, it's everything. Ethiopia has one doctor for 42,000. Remember, Tanzania and Ethiopia are at the bottom of that visual that talks about physician numbers. Ethiopia is a fascinating experiment to watch. I shouldn't call it an experiment. In a way, it's an innovation. The government of Ethiopia has decided we're no longer going to sit back and be at the bottom of this list. We are going to invest heavily and we're going to flood our training programs. We're not going to only flood the existing programs, we're going to expand the number of programs. So when we went year after year to Ethiopia, one year there was 12 medical schools and then the next year there were 23. I mean, they have really expanded the number of health professions training programs. So much so that at Addis Ababa University, within a couple of years, the class sizes had quadrupled. So you can only imagine this setting of a workforce training program that's trying its best to produce good health professionals, all of a sudden has quadrupled class sizes, no investment in textbooks, no investment in infrastructure. So if you ask what's driving e-learning, expanding class sizes, access to information, can't produce workers who don't have access to something to learn, but not only do they need information to learn from, they need to keep up with all the evidence that's being produced. And then faculty attrition, which we talked about. So this was the nature of the investment. The schools in MEPI invested, all of them invested in technology. They invested in giving their students devices. So Ethiopia bought 5,000 devices to give to their medical students. Before MEPI, or at the beginning of MEPI, when we went in, the students were telling us there was like one textbook for 15 students. They would wake up at 6 a.m. to go to the library, to stand in line, wait 2 hours to get a textbook for 2 hours, and then they would have to return it. So imagine the challenge and the attrition that comes when you're struggling to have enough learning resources. So they bought devices. They upgraded infrastructure. There was faculty development across the MEPI schools, learning management systems, somewhere to anchor all of this material, and digitized content, for example. In South Africa, they produced podcasts that were really, really popular with the medical students. All right, so the question is, you invest in technology, so what? Because 4 years ago, I gave a talk on MEPI, and we talked about the same thing so far. So you would have seen similar slides that this is what they're going to do. So now the question is, what happened? So the schools report staff retention, a shift in culture, and improved access. In fact, in Tanzania, they've started to track faculty satisfaction, faculty retention, and they're seeing the curve go up. Faculty are indicating that they are more inclined to stay at KCMC. This one I find particularly interesting. They bought devices, they expanded the bandwidth, and almost 50% of the students bought their own device. You build the highway, the cars will come. This, I think, is a shift in culture. When we're thinking about producing a workforce that will think creatively, that will innovate, that will keep up with the vast amounts of information, we need our workforce to have access to what's available online. But we need them to desire it and crave it so that it becomes part of their practice. So the fact that 50% were inclined enough to buy their own device is notable. And more than that, 100% of them almost, 96%, were accessing online educational material. This shift in culture, I think, is important. And what happened in Ethiopia? I mean, their staff turnover rate before MEPI, they claim was over 100%. There was just a rapid turnover of faculty at Addis Ababa University, and it's gone down to 24%. The investment in strengthening the conditions of academia have borne fruits. 15% increase in students who graduated with distinction. You can imagine, quadrupling class sizes, their attrition rate went up. People were not making the mark. Not only have they been able to stabilize the attrition rate, they've actually been able to increase the performance, which I find quite interesting and impressive. And not so measurable, but I think it's notable that this investment in technology allowed a sharing of information, not just information, sharing of resources in the country in Ethiopia. So I think what we'll see in time to come is that they've actually increased the bandwidth and capacity nationally by sharing digital resources, by sharing material even across the landscape of the country. All right, I'm going to hop over. So we were talking about workforce education. I'm going to hop to the other side of the health system and talk about service delivery environments, and I'm going to totally jump geographically. Tajikistan. So I don't know, has anyone here worked in Tajikistan a little bit? One of my favorite countries. It is absolutely beautiful. Tajikistan is post-Russian, was gained independence in 1991. 8 million people, it is the poorest country of the Central Asian countries. But it's a fascinating country because if you look, they have almost the same number of their physician workforce is similar to Canada. But this is a 93% mountainous population. I like this picture because you can imagine being one of those villagers living in a village in between two mountains. Very vulnerable populations. They're subject to natural disasters, they have limited access, you name it. 26% urban, so the majority are actually living amongst these mountains, but 99% literacy. So this is an example of a healthcare system that doesn't struggle with numbers of workforce, but the quality. So this, in the Russian times, the health system was really based, the Soviet time, yes, good correction. Soviet times, the healthcare system was really specialist focused. So they produced mass amounts of specialists. There was no such thing as primary care. You have a breast lump, you go to the oncologist. Your heart aches, you go to the cardiologist. So lots of physicians trained as specialists, poorly compensated, $150 a month is the current compensation for a physician in Tajikistan. Poor infrastructure because while there used to be vibrant health clinics, they now stand dormant. And there's no real residency training. To be a specialist, you basically do an apprenticeship or an attachment with a specialist and then you come back and practice. So the government is refocusing on primary care. And they're saying, let's take all those specialists and retrain them as actually family medicine doctors. So they've got a 6-month curriculum that they take existing doctors from wherever they are, they bring them to a training center, train them up as family medicine doctors, and go back out. The challenge is not just 6 months is not enough to produce a quality workforce, but how do you generate demand from a patient population that doesn't even know what primary care is? They've always thought to go to the specialist. They don't know to go to a family medicine doctor, and who and what do I do with that doctor? So the partners we worked with in Tajikistan said, we have a couple of problems. This country in particular struggles with NCDs. 60% mortality rate from NCDs, 40% from heart disease, 8% from cancer. But they came to us with a specific problem. Women are dying of breast cancer. They present late, they have a lump, but they wait forever to present it, and then there's mortality. And it's a vicious cycle because now women who know their friend went to the doctor, had a breast lump, died, I'm even more reluctant to go and show anybody my breast lump. So that was the problem that they came to us with. And it wasn't just that we said, let's just train on screening. It was a really community-based approach. So what our team did was train the community health workers. So in Tajikistan, they have community health promoters who really focus on health promotion. We trained the community health promoters. We trained the family medicine doctors to do clinical breast exams. Although they had learned it in their 6-month curriculum, they really weren't feeling very confident or proficient. And we conducted a community-based campaign. So during this campaign, we lined up the women, there was a big marketing effort. And over time, we continued to work with the family medicine doctors to track the results of their effort. So this was the team of doctors that we worked with, and what were the results? So we trained 24 family medicine doctors, identified the 10 best at that time, and engaged them as trainers. During the campaign, we screened 441 women, but even more importantly, in the year that followed, they screened 3,000 women, and even more importantly, it was in the clinics, not in campaign setting. Women were bringing their kids for immunization, and they were saying, can I get a clinical breast exam? Can I get a breast exam? Or the family medicine doctors were saying, can I offer you a breast exam? And even better, they're now reporting that in their monthly numbers to the government. So this was an effort where you go right into the community, look at the way that care is provided, and because the community health promoters were really part of this package, right? They needed to generate demand in order for the patients to be coming, and then the performance of the workers has improved, the health workers, the family medicine doctors. So that's the other sort of at the end of the pipeline, looking at the existing workforce. I'm going to go back a little bit and talk about the trend of decentralization. So this is the third innovation that I wanted to talk about, is decentralization of medical or health professions education. And here I'm going to go back to MEPI and particularly look at the University of Nairobi. I went to University of Nairobi in, I think the second year was my first year going there. And the students there were telling us, look, our class size has increased. Yes, we're all happy about that because we talk about workforce crisis. We need numbers. But now, we're so many in a class that when I go to the patient's bed, there's 20 of us. how do you expect me to know how to deliver a baby when I go do my obstetrics rotation at Kenyatta National Hospital and we're all competing to get our hands on the baby, so I might, at best, have delivered one baby under assistance. Well, I can't come out to be a good doctor, and then you're going to go put me do my internship in some remote part of the country and expect me to be proficient? This doesn't work. So in Kenya, and much like most of the other schools in MEPI, they created what even they called decentralized training sites. So they took the students and they said, we're going to send you to Garissa. So in Kenya, Garissa is, you might have even heard of it because there was a terrorist attack there. It's actually far in parts of Kenya that are not very secure. They sent the students there to work. What happened when they sent students there? The students loved it because they actually got to see patients and take care of patients and hands-on. The staff at Garissa, who was planning to move back to Nairobi, came and said, I'm not going to move. The students came to me. I like my job. And the students, even at times when the issues of security were so high that the university leadership was saying, you need to come back, they said, no, we're here to take care of the community. So the connection between the students and the community improved, the clinical skills of the students improved, and the staff at that site were happier in their jobs. And the same sort of trend has happened across the continent for different reasons. Nigeria, same thing, crowded tertiary hospitals. They decided they're going to use their PEPFAR sites for not just public health or research. They're actually going to send their students there for training in surgery and OB. In South Africa, actually post-MEPI, they have a huge CDC grant to develop a national model, which will have a menu. It won't be a model, but for decentralized training. There's a recognition that getting our students out of the tertiary hospital has value to the health services. Same thing in Tanzania. And in Tanzania, because they recognize that when you send students out, you don't really know what's happening in terms of the quality of the education, they sent them out with a kit of point-of-care diagnostics and with a faculty member who didn't stay, but who went and periodically came back. So they're sending a specialist to these remote areas to supervise the students, but guess what? That ID doc who's going there for a week can also provide some services. And Uganda, the same. I mean, the list could go on. Uganda is known for their community-based efforts and training in the community, and what they did was set some standards and criteria for what constitutes a good training site in the community. So the question is, you decentralize, interesting innovation, what happens? So in the MEPI community, we had technical working groups in common areas of interest, and we developed, one of them was the community-based education technical working group, which actually worked very closely with some of the folks around the table here. So going site to site in the early years of MEPI, there was something happening. You go to the community sites and you hear the stories I just told you, the story from Garissa, where the staff were happier, where the students were getting, there was something happening here, yet if you looked at the evaluation plans of the medical schools, they hadn't really evolved. They were still measuring student performance on exams, student experience with the rotation. They weren't measuring from the other aspect. What happened to the health facility when you started sending students there? So we've now got a study that I'm leading across the MEPI schools, and even though MEPI is winding down, this study is still going strong. In fact, it's so strong, it's an unfunded study with PIs in all of the 11 schools of MEPI. 10 countries, 11 schools, unfunded leads across, and everybody's interested to look at what happens when you bring academic rigor and resources outside of the tertiary hospital. So we've got 22 sites, half rural, half urban or peri-urban, 66 interviews, and this was really a qualitative exploratory study to say, let's talk to the facility manager, let's talk to the person who was supervising the student, and let's talk to some other provider at the site who can all tell us what happens or what happened when students started coming. So, from the lens of the training program, from the health professions education program, the students told us what I just shared. They got opportunities for clinical skills, they were working in interprofessional teams very intimately, and they experienced a different case mix. This case mix was the real country case mix. And interestingly, for example, Nairobi, that identified adjunct faculty within the sites, those faculty became a greater pool of faculty. So where I was describing before, one of the greatest challenges for the medical schools in the pipeline of health professions education is faculty, this became a way to expand that pool by providing training, resources, incentives to the staff existing in those sites and making them adjunct faculty. But to me, what's really, really fascinating, so in the study that we're running, we've just finally in the last 2 to 3 weeks collected the last bits of data. So we got data from 11 sites, 11 schools in 10 countries, and here's what they're telling us. Everybody is like waking up and trying to be up to date. This is in Botswana. The biggest benefit of having students here is the continuous involvement in the improvement in the quality of care. We have achieved 100% testing in certain wards. This is a site that's telling us we used to have our HIV testing was 60%. We're now near 100%. If you're looking for measurable metrics in the health service field, here's one. They ask me questions and I answer them. Sometimes I also get answers from them for situations that are beyond my knowledge. These are those synergistic moments of, mutual benefit. And last one, the work is easier. And the dynamicism increases a great deal for looking for new knowledge, and the team is involved. So when we think back to how we're going to bridge the gap in the workforce crisis, and we need to innovate and we need to be creative, I see here there's an opportunity. So this is the lens that I should say here that this was not meant to be an all-inclusive look at MEPI. MEPI had many innovations and many stories to tell. I picked these three because I think that they were interesting innovations that spoke about quality, and the results were really around quality. I leave, or at least complete this part of the session with a couple of thoughts, although many emerge as I reflect on this information. How do we balance the quality, the desire and the craving to train for international markets, but the real need in quality to look at the local standards, the local needs and the local context? How do you create a global dialogue when it's so much about local? And more importantly, I think, is this issue about engaging new partners. If we want, in the workforce field, to engage new partners in financing in particular, then we need to start speaking their language. They're not so interested in how the students performed on the test. They're interested in maternal mortality. They're interested in male circumcisions. And when you talk, and I was just at a workshop in South Africa that they had asked me to come and work on, the schools from the different medical schools in South Africa all presented their model of decentralized training. They reported when the students started to come, we saw a reduction in maternal mortality. When the students started to come, we saw a reduction in the complication of male circumcision. Now, yes, there probably is multifactorial, but they said the timing was such that we did see a reduction. I think we need to do a better job of capturing these outcomes of academia, of our academic investment, and how it connects with the health system. So that's it. I wanted to leave with this last slide that you've seen a couple times in my presentation. I think the workforce crisis is not just one of numbers. I think the issue is also quality, and I see in the dilemma of quality opportunity. That if we can shift the conversation, think creatively, think innovatively, maybe even the numbers will be different.